of MRD in myeloma, I was privileged to participate in a panel this year's ASH with all the heme malignancies. And what's interesting is that when we look at AML, CLL, ALL, and myeloma, and the story is the same in all four of these diseases with one exception, which is ALL. MRD is a great surrogate endpoint. In study after study in randomized clinical trials is showing that better MRD negativity translates into the survival endpoints of PFS and perhaps OS. The problem, though, is we have to decide, is this a prognostic or predictive test? Some of the things that are involved in that discussion are, do we have studies that say if you're MRD positive, you need to intensify therapy? Or if you're MRD negative, can you discontinue or de-intensify therapy? And so those would require risk-adapted designs, and right now we don't have any of those results. So in 2019, other than ALL, where there is a MRD positive negative alteration in your treatment, no other heme malignancy do we have MRD as a predictive marker. The one other caveat I would like to make for MRD is that myeloma is very different from these other tumors because it is essentially a blend of a liquid and solid tumor. And we know that patients can have osseous disease and people can have macrofocal disease. So if you sample a patient's bone marrow and it's MRD negative, but they have residual radiologic disease, what does it mean to be negative from that one sample? So some of the things that we need to think about in using MRD in myeloma are thinking about the PET scan or MRI to make sure there's radiologic negativity, making sure that the sample was collected properly and it was a first pull, making sure there were enough events to count, because if you do next-gen flow and the marrow is essentially empty or cellular, it's going to be falsely negative. And finally, also, is it sustained MRD negativity? So single time point is not enough. We've already seen that in Forte study, patients with high-risk disease in particular are relapsing earlier, even though they had MRD negativity. And so I think the sustaining of MRD, particularly for high risk, is important. So we have a lot of things to grapple with. And finally, I would close by saying, how am I using MRD right now in 2019? In my practice, because of the lack of evidence, it's hard to justify, but probably the two areas I sometimes will consider it would be a transplant-eligible patient who gets induction therapy and the post-induction marrow is MRD negative, and if the patient is averse to getting a transplant, it reassures me and the patient that, okay, it's maybe okay to defer the transplant for this patient. Conversely, in a patient who's low risk and MRD negative, sometimes I also use it if they're having difficulty tolerating treatment. And if it's MRD negative and they're a low-risk patient, we have a risk-benefit discussion that maybe it's appropriate to hold therapy and monitor them. But other than those two very unique, limited settings, I'm not using it routinely in my practice. The utility of MRD may also differ based on the patient population. So for example, in the Forte study, those patients who were low risk, so ISS1, revised ISS1, MRD negativity seemed to be comparable in the two arms, which is KRD for 12 months versus KRD with a transplant consolidation embedded into it. However, for those patients who were high risk, revised ISS 2 or 3, there were more early relapses in the non-transplant arm. And so I think this is an important finding because not all patients are created equal, and the risk of a patient may matter. While some studies are showing that the MRD negativity can make a high-risk patient have a comparable outcome to standard risk, there are also many studies that show that even if you're MRD negative, as a high-risk patient, you still do worse than standard risk. So I think we need a little bit more data, and part of that may also be the ability to sustain an MRD, because if you're a high-risk patient and you have a single time point of MRD negativity, is that the same as now becoming standard risk? And I think so we need a little bit more information, but I think this is an interesting area of research.